Good morning, everybody. It's Michele Andrews representing the American Heart Association as an instructor. I am coming to you this morning to bring some ACLS test prep questions and considerations. All right, for you to be studying and reading on while you prepare for your ACLS test. Before I go there, may I ask if you'll like my channel, subscribe to my channel, and or comment on my channel. All of this helps with the algorithm to get this information out to as many people as possible. And so that's what I'm trying to do. And so every subscription, every like, every comment, it all helps to get it out there to everybody. Okay? All right. So without further delay, we want to jump right into our ACLS test prep. And it's jam-packed. So we're going to start out with the basics, BLS. Right? So with BLS, I am going to look down quite often because I have my notes all right in front of me. Okay, so I apologize if I'm not looking at the screen the entire time. I want to look at you, but the notes are in front of me. So I'll do the best I can to look at them minimally. Did I say that right? Starting with BLS, the first link in the chain of survival, right, is my patient unresponsive? Is my patient not breathing? Does my patient have a pulse? Those are the first three things we check, and that makes up the first link in the chain of survival. Unresponsive, not breathing, does not have a pulse. Call 911. Or call the code, depending on where you're at, right? So knowing that on the test is important. You need to know that first link in the chain of survival. They're unresponsive, they're not breathing, they do not have a pulse. Know that. In the second link in the chain of survival is CPR, right? And so we want to remember that we go down 2.5 inches on your average adult. Okay? Something that I starred is that we want to go 100 to 120 times per minute. Okay? Don't forget that. Write that down. We're going to do 5 sets of 30 compressions to 2 breaths. Now, let's talk about those breaths. You know, in the hospital, in the acute care setting, you've got respiratory at the head of the bed doing what we call asynchronous ventilation. But really, we're counting 6, 5, 4, 3, 2, 1. She's coming up on the chest, we squeeze the ambu bag. She's coming up on the chest, we squeeze the ambu bag. That's our 2 breaths. And so every 6 seconds, I starred that. Every 6 seconds, we're giving breaths. That's also with rescue breathing too. Every 6 seconds, we give a breath for rescue breathing. Know that. Know that it shouldn't take any more than, 5 to 10 seconds to check for a pulse. Know that. 5 to 10 seconds is a perfectly acceptable answer, okay, to check for a pulse. Also, no more than 10 seconds off the chest. Guys, I'm throwing this at you kind of fast. I'm trying to talk slow because I want you to write it down. These are all important things, or I would not say them. I am test prepping you. All right. No more than 10 seconds off the chest. So, from the time that we place that board under our patient to the time that we might be intubating, to the time that we're switching compressors, no more than 10 seconds off the chest. And that's American Heart Association's recommendation. Okay? The third link in the chain of survival is AED or defibrillation. So, American Heart Association changed this a few years ago, but I want to make sure you remember it. Do we stop CPR while the defibrillator is charging? No, we don't. We continue CPR during the defibrillator charge, and we charge that defibrillator 15 seconds prior to checking for a pulse. Okay? The fourth link in the chain of survival is the emergency medical services, or EMS. All right? What can they do that would increase the patient's chance of survival, or give the team there at the hospital some good insight as to what is coming in that door? They could notify the hospital of their findings, right, while they're on their way in. So pre-notification is a great thing that EMS can do to increase the patient's chance of survival and give the team that's waiting for this patient some just good findings. The fifth link in the chain of survival is treatment, or the hospital. Under that, I starred a couple of things. I starred that the contact out in the field for a STEMI to the balloon time is no more than 90 minutes. That's what we shoot for. So from out in the field, the contact that the EMS has made to the time that we get ready to put in that stent, it's no more than 90 minutes. Which I start here, which facility is going to be best for a STEMI or a stroke? Either one, really. Think about it. Is it the closest hospital, or is it the closest hospital that can treat the patient with the appropriate departments, such as a cath lab, a CAT scan, a hospital that has a neurologist, right, in case they have a hemorrhagic bleed, hemorrhagic stroke. So, which hospital is best? The one that's closest that can, intervene for the patient. That's the one we're going to choose. I also start under the fifth link in the chain of survival, under treatment. We were talking about STEMIs and which hospital we would take. Let's say that we're doing chest compressions all the way to the hospital. We get to the hospital, the patient returns to ROSC. We go ahead and perform whatever needs to be done that caused that patient to develop a STEMI in the first place. So whether that be the OR or whether that be the cath lab, we've completed that and we've taken them, to the ICU. It is recommended by the American Heart Association that we provide target temperature for them and that's at 32 to 36 degrees Celsius. For how long? 24 hours. So I said that a little slow. Target temperature management is what we do for our post-ROSC patients. 32 to 36 degrees Celsius for 24 hours. Okay? That was your BLS. We went through all 5 links in the chain of survival. Let's talk about some high team dynamics. High team dynamics is really about communicating appropriately between one another, because it is so important in a code situation, in a rapid response situation, in an emergent situation. It's important that we communicate appropriately between each other. So some things I starred that I thought were important for you to study and read up on for this ACLS extravaganza, the test that you'll take that will gain you your ACLS card for 2 more years. Some things I starred were beginning of code. The CPR coach should delegate tasks or roles. That is recommended. So, if you're the CPR coach, you should be delegating the roles and the tasks for each individual that's going to participate in that code prior to that victim arriving, if you can. What if it's a rapid response and it turns nasty? Do it as fast as you can. Know your people. Know who your respiratory therapists are. Know who your RNs are. Know who your CNAs are. They're all helpful in a code situation. Your team coach should, let's say the team coach gave me, as a respiratory therapist, the role to put an IO in. I'm going to have to ask for a new task or role, aren't I? Because I don't do that, right? Same thing if an RN were to be given the role or task of being at the head of the bed and ventilating and possibly suctioning and intubating and placing on a ventilator or drawing an ABG, what have you. The RN doesn't do that. That's the role of the respiratory therapist. So that RN would ask for a new role or task, okay? That's important to know. So all of your questions that you ask, let's say, for example, you're in a noisy environment and you think you hear the CPR coach recommend 0.01 milligrams of epinephrine. To clarify that, the best way to do that would be to say, I'm giving 0.01 milligrams of epinephrine. Is this correct? That's the best way to respond to your CPR coach, who in a noisy environment may have said the wrong amount, or you might have heard the wrong amount. Okay? So that's important. If a team member is doing something wrong, address the team member immediately. And that is something on the test. And it's a high team dynamics topic. So I think that it's important that if American Heart brings it up, I think it's important for us to know that, you know, if a team member is doing something wrong, for example, if they're not going deep enough on their compressions, or they're not recoiling all the way back up so the heart can refill, we want to address that immediately. If they're going too slow, we want to address that. If they're going too fast, we want to address that. immediately. Another thing I started was reason for RRT or emergent teams. So, what is the reason that we have rapid response teams or emergent teams these days? Why did they pop up? All of a sudden, they just kind of started popping up everywhere. And every hospital has one now that I know of. And so it's important because the patient outcome is improved by addressing their clinical deterioration immediately. That's why rapid response teams or emergent teams are so important, is because we're addressing their clinical deterioration immediately. And finally, the purpose of the CPR coach is it's a positive thing to have a CPR coach to ensure that there's high quality CPR given at all times. That I would hate to be the CPR coach because there's so many things that they have to remember and so many roles that they have to play. But one of the things that is very important, and American Heart was sure to point this out, was that we want to make sure that our CPR coach is able to establish high quality CPR. Whether we're using devices at our hospital that tell us that we're doing quality CPR, whether we're using capnography, which we'll get into. So these are all important. All right, pieces of the CPR leader's role. Okay, let's get into acute coronary syndrome a little bit. One of the things that I started was the signs of acute coronary syndrome or cardiac arrest is agonal gasp. I want you to know that agonal gasp is not normal breathing, and it is a sign of cardiac or pending cardiac arrest. Okay, you need to know that. All right, also too, you need to know that when you first suspect a cardiac arrest, what do you think the first assessment will be done? Could be. Would be done is an EKG. Do we want to get labs? Absolutely. Do we want to hook them up to the monitor? Absolutely. We want to get all those vitals. But an EKG, if you suspect pending or a current cardiac arrest, you want an EKG immediately. Okay, so that would be the correct answer. Under acute coronary syndrome, if you suspect acute coronary syndrome, how much aspirin should you give? I think this is on every test, and I want to make sure you remember it. It's 162 to 325 milligrams, okay? 162 to 325 milligrams of aspirin for a suspected acute coronary syndrome. Also, during bag mask ventilation, we talked about this. How often do we give those breaths? We said in one of the links of the chain of survival, every 6 seconds. But I want to talk about something even further. If I were to give excessive ventilation, excessive bag mask ventilation, and I wasn't waiting those 6 seconds, but I was just, that's excessive ventilation. What's going to happen to our cardiac output? It's going to decrease. Why? Because excessive ventilation increases the intrathoracic pressure, which puts pressure on the heart. So remember that, okay? That's important to know. All right. This is a post-cardiac arrest kind of question, and it's something that American Heart asks a lot on my students' test, and that is, what is the systolic blood pressure that we try to achieve post cardiac arrest? 90. 90. That's your answer. 90 systolic blood pressure. Okay. The goal time from the EMS to the cath lab, we talked about this, was 90 minutes. 90 minutes. I said that again. Okay. I want to review capnography. Okay. Capnography is the ability to measure exhaled CO2. All right. Now, if I have an ET tube in the patient's trachea, I can place a little plastic piece on the end of that ET tube, and then there's a little wire that comes off of it and goes up to the monitor. And that measures a normal CO2 of a spontaneously beating heart of 35 to 45, okay? So I think to establish what normal is a great place to start. 35 to 45 for CO2 is normal. Now let's start there. What are the valuable things about capnography? And American Heart is bringing this up more and more and more. So it's worth listening to. Number one, it shows placement quickly. Quickly. If I intubate that patient and I've intubated into the esophagus, what do you think my CO2 reading is going to be on my telemetry? 0. And if you said 0, you're right. Because there is no CO2 in the esophagus. But if I yield back anything besides 0, I can almost be sure I'm in the trachea. The second thing that's wonderful about capnography is it shows quality CPR. We don't need those special gadgets and whatnot if we're using capnography, because we know that normal for a spontaneously beating heart is 35 to 45. Now, American Heart Association is telling us that for a non-spontaneously beating heart, that being one that we're manually compressing, we should yield a CO2 of somewhere around 10 to 15, maybe 16 or 17. That's what we should yield if we're going down 2.5 inches on your average adult, and you're recoiling all the way back up. You're going 100 to 120 times a minute. So you're doing quality CPR. Quality CPR will yield back a capnography reading of 10 to 15, maybe 16 or 17. That's the second thing that's wonderful about capnography. And again, I'm trying to go slow so you can jot this all down. Number 3. The third and final thing that's wonderful about capnography is that it can immediately show us if our patient has returned to ROSC. How? Well, our documenter is keeping an eye on the vitals of the patient, and she notices that the CO2 jumps to 38. That falls in normal range, doesn't it? It does. And so she lets the doctor know, Doc, the CO2 has just jumped to 38. What's the doctor going to say? Hold compressions, check for a pulse. I think our patient has returned to spontaneous circulation. And so very quickly, capnography can show us that our patient has returned to spontaneous circulation. And those are the 3 things that are wonderful about capnography. And I wanted to share those with you because they are important for your test prep. Okay? Now, the other thing that I wanted to go over with you is a few rhythms. The first rhythm that I'm going to go over with you, I'm just going to kind of hold up close. It says it there. Don't be scared to say it. It's SVT, but why is more important. Why? Because I don't see a P or a clear-cut T. I see a beautiful QRS, but I don't see a P or a clear-cut T. And you nurses taught me that a tachycardia without a P is oftentimes SVT. A tachycardia without a P is oftentimes SVT. How do we treat SVT? Well, they're in our tachycardia circle. If you took my class, you understand what that means. If they are, let's go ahead and turn this around. Whoops, I'm sorry. If they are symptomatic, if our SVT patient is symptomatic, they're immediately getting cardioverted. So, SVT with symptomatic signs, very symptomatic. Altered mental status, low blood pressure, just a train wreck. They're getting cardioverted. We don't have time for adenosine or vagal maneuvers. We did try vagal maneuvers early on and they didn't work. SVT continued. So, if they're symptomatic, they're getting cardioverted. Now, if they're not symptomatic, then we could consider vagal maneuvers and we can consider 6 milligrams of adenosine. And the doctor may even order 12 milligrams of adenosine for our non-symptomatic SVT patients. Okay? Now, that you know that, let's talk about this one here. Monomorphic VTAC, right? There's no P, there's no T anywhere in here. This is just straight QRS, 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 QRS. And it's the same shape. Mono means one, morphology means shape. One shape of VTAC. So monomorphic VTAC is something you're going to see a lot on American Heart Association tests. Why? Because she's bipolar. She can be treated cardioverted or she could be defibrillated. And I'm going to give you an example. But this one makes you think. So you have all the signs that you have a symptomatic patient. You have a low blood pressure. You have a low, an increased elevated tachy heart rate. You have weak, thready pulse. And so all your signs are showing that, the patient is symptomatic. But they do have a pulse with monomorphic VTAC. And so if they do, we're going to cardiovert them. Symptomatic with a pulse gets cardioverted. Symptomatic without a pulse gets defibrillated. Why? Because they're pulseless VTAC. That's why. Okay? So, monomorphic VTAC, symptomatic without a pulse, gets defibrillated. Speaking of defibrillation, I want you to be able to recognize VFib. Write that down. Was trying to see if I had a quick run of V-fib real quick. I do. This is a fine V-fib, but nonetheless, it's still V-fib. You can have coarse V-fib, you can have fine V-fib, but right here is V-fib, okay? So right there's V-fib, that's fine V-fib. You can see there's no P, there's no QRS, there's no T. It's just energy going blah, 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 blah. That's V-fib. Speaking of V-fib, know your algorithm for V-fib. CPR always comes before, or BLS always comes before ACLS. So CPR first, then we shock. Then we resume CPR. Do we stop and check for a pulse? No, we do not. We resume CPR. Then we shock again. We do 2 shocks at the very beginning of V-fib or pulseless V-tach. Okay? And pulseless V-tach is monomorphic V-tach without a pulse. That's pulseless V-tach. So if I showed you this one right here and said she has no pulse, you're going to say that's pulseless V-tach. That's not monomorphic V-tach. That's pulseless V-tach. And you're right. CPR, shock. CPR, shock. CPR, epi. CPR, shock. CPR, amiodarone. 300 milligrams. CPR, shock. Know that algorithm. I will say it one more time. CPR, shock. CPR, shock. CPR, epi, 1 milligram. CPR, shock. CPR, amiodarone, 300 milligrams. CPR, shock. You need to know that algorithm for V-fib and pulseless V-tach, okay? And then finally, I want you to review your heart blocks, your secondary heart block and your 3rd degree heart block. I have it up here on the board. I hesitate on going up there. I don't want to ruin this perfectly beautiful video, but I'm going to go up there anyway because I'm just that kind of person. I'd rather be right than it look perfect. So we're going to go ahead and turn you around. Okay, let's get up close and personal. First off, all right, we're going to talk about 2nd degree heart blocks. 1 and 2. All right? 1. Look, guys. Heart blocks are all about electricity. They're not about mechanical operation of the heart. They're about electricity. Do you remember in A&P 101 when we talked about, look at this beautiful heart, SA node, AV node, bundle of His, Purkinje fibers, and then, you know, what connects them is the conduction wire, if you will. SA node to the AV node to the bundle of His to the Purkinje fibers. That's what your blocks are all about. They're all about the electricity of the heart. Do you remember, I've told you, if you haven't watched my ACLS class, it's on YouTube, you need to watch it, because I told you that the atria are represented by the P wave. The QRS is represented by I did that backwards, didn't I? Haha. Ventricles are represented by the QRS wave. Now, knowing that, would it make sense to you if I said that blocks are all about the relationship in time between the P and the QRS complex? The relationship in time. Keep that in mind as I show you what a first-degree heart block looks like, okay? Right here, I have a P wave. I told you the relationship in time between the P and the QRS wave is what determines which block we're in. Well, in this case, number 13, if you have the packet in front of you, you see the P to the QRS is, I'm guesstimating, okay, because I know that each block is 0.20 seconds. So I'm just going to guesstimate and say this is about 0.18 seconds. T wave, P wave. Now it's 0.22 seconds. T wave, P wave. Now it's 0.36 seconds. T wave, P wave. Whoopsie doopsie, dropped one. Okay, we start over. P wave, T wave, 0.16. P wave, QRS, T wave, there's your T wave. P wave to your QRS wave. Now we're looking at maybe 0.20. T wave, P wave to the QRS wave is now about 0.38. There's your P wave, and whoopsie, we dropped another one. What did we see as a pattern here? Our P to our QRS got long, then it got longer, then it got longest, then it dropped. Then it got long, then it got longer, then it got longest, and then it dropped. And it's going to do it again. Long, longer, longest, drop. Then you have the winky buck. That is second degree heart block type 1. Okay? Second degree heart block type 2. I want you to review that one as well. Very quickly, I will just tell you that if we're talking about it being about the relationship between the P and the QRS complex, look at the P and the QRS complex in heart block, second degree heart block type 2. Whenever they're together, they're the same. If I had my protractor out, it'd be 0.04 seconds apart every single time they're together. Okay? Whenever they're together, they're the same. That's a second degree heart block type 2. P to the QRS is the same. In type 1, the P to the QRS is long, longer, longest. Now, how about, let's talk about third degree heart block, or what we know in the hospital as a complete heart block, right? Yes. All right, so right here in a third degree heart block, we never drop a QRS complex. It's always present. It just keeps beating very regularly. It just keeps doing what it knows to do, right? But I told you the relationship between the P and the QRS is what blocks are all about. And the time between the P to the QRS, if I have my protractor out, is all over the place. In every single segment, they're different. In every segment, they're different. In every segment, they're different. You see that? They're different. In every segment, the time is different. We call that disassociation. The P to the QRS in a third degree heart block, the P to the QRS is not communicating at all. at all. They're not communicating. If you need to know and understand heart blocks or any other heart rhythm, such as SVT, VFib, monomorphic VTAC, pulseless VTAC, and their algorithms, take my ACLS class. It's right on YouTube. I really encourage you to go review at least that portion of it prior to your test, okay? All right. So I think we've covered most everything that you need to review. There's a couple of things I left out, but they're common sense questions. They're scenarios. So pay attention to what's normal, what's not normal. And then if you know your rhythms and you know those algorithms, you're going to do just fine on those scenario questions. There's only 2. All right? It's Michelle signing out. I'll see you next time. I'm gearing up for a brand new ACLS class. So watch the old one now because it's good. Watch it now before your test. And I'll see you next time. Bye-bye.